The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. Hey, welcome back to Knowledgeable Provider. I'm Jody Marks. In medical news this week, the new ACIP panel met and apparently had a pretty chaotic meeting. I've seen all kinds of news stories about this, and it's been a little difficult to make heads or tails of what actually happened. I'm recording this on Saturday, September 20th, so maybe this will have changed by the time this episode comes out on Monday. But as of right now, I believe where things stand is the ACIP has made a recommendation not to use the combination MMR-V vaccine for children under 4 years of age. That would be measles, mumps, rubella, and varicella. I don't really want to say what I'm about to say, but I think it's the truth. I think the popular media is making a little bit more out of this than it really maybe is. All the news stories I read kind of made it sound like they're saying children should not be vaccinated for these things. If you actually read the literature from the actual committee, they're saying that there is an increased risk of febrile seizures in little kids who get the combination, the MMR plus V, so one shot together. They are not actually saying that children should not be vaccinated. They're just recommending that it be done with the separate MMR and varicella vaccines, so 2 shots instead of 1 combination shot. Evidently, some of the experts involved had issues with the data that they presented to justify this. And I honestly am not really qualified to evaluate the validity of this data that these expert people are presenting, so I'm just not going to do that. They had also talked about reviewing the Hepatitis B vaccine, which is currently recommended to be given to all newborns. They acted like they were going to stop that, but then they tabled actually voting on it, so they haven't made any changes there. I mentioned before that I think I'm going to start paying more attention to what the professional medical societies are recommending and not so much what's coming out of the CDC, at least for the next 3.5 years or so. So I'll post a link to the vaccine schedule that the American Academy of Pediatrics recommends in the show notes. I'll also put links to the documents that were put out by the ACIP regarding this most recent discussion that they had, and you can decide for yourself whether it's valid or not. In personal news, I told you I would update you about my transition from Epocrates to Open Evidence and MD Calc. So far, overall positive. It is pretty neat to get in Open Evidence and just ask a question like you would ask to ChatGPT. It seems to give just about the right amount of information. It kind of puts the short answer to the question you asked in bold, and then it gives you a couple paragraphs after that of background information and shows you references. And like ChatGPT does, it will kind of offer to do a next step. It'll say, do you want me to create a patient handout about this, or do you want me to summarize this or that? Overall, pretty cool. I think I already mentioned that I got an incorrect response from it about whether or not the 4K score for prostate cancer was FDA approved. I sent them an email about that and got a pretty quick response, and they said, hey, we're going to change how it answers that particular question or questions about FDA approval. Thanks for the input. So I thought that was a decent response. Glad to know someone's paying attention at least. Another thing about it, I'm not sure if I already mentioned this before. If I did, I apologize. But you can go back and review your queries. You can go back and review the answers to your own questions and get CME credit from it. So that's pretty cool. MD Calc is fine. I went through and favorited all the same calculators that I had in Epocrates, and it seems to work. I don't really have any criticism of it. You do see some ads, and there are some ads in Open Evidence, but I suppose that's why they are free, or that's why they can be free, so I don't mind that. Probably the calculators that I use the most are the cardiovascular risk assessment tools. I've been using the AHA-ACC calculator with the 2018 pooled equations. I've been wanting to switch to the Prevent calculator, which was not available in Epocrates, but it is available on MD Calc, so that's what I've been using. And in order to use that one, you have to put in a GFR, and for whatever reason, our lab does not calculate the GFR. You just see the BU and creatinine and then the ratio. So in MD Calc, I've been flipping back and forth between the eGFR calculator and the Prevent calculator. One thing I do find funny is that when you put in the values for the patient's cholesterol, blood pressure, BMI, those kind of things. If it's really much outside of the normal range, it will flag it and go, this is very high, make sure it's accurate, or this is very low, make sure it's accurate. And it's like, well, yeah, these numbers are going to be somewhere in the range, which is why I'm calculating the cardiovascular risk, right? And it won't do a BMI over like 39 or 40, just like the AHA ACC calculator. It won't do a total cholesterol less than 130. It seems like there's something else that it wouldn't accept the other day that was, a fairly common number. I don't remember. Overall, fine. I've not regretted the switch so far, so I'm going to stay with these things for now. I used open evidence to ask a question about summarizing some information that I'm going to give you in this podcast episode, and it did a very nice job with that. So handy little tool there. I'm probably not quite as enthusiastic about AI as I was when I made my episode about AI. After having some experience with ChatGPT and some other little chat bots here and there, I can totally see how you could get pulled in and start to form some crazy thoughts based on the conversation that you're having with your AI companion. And there are these stories about these teenagers who have committed suicide, or that one guy that went and tried to assassinate the queen. And those kids were all having kind of intense relationships and very frequent conversations with their AI chatbots. So it's definitely something we have to be careful with, like all technology, I suppose. I listen to a podcast called Your Undivided Attention, which is made by the Center for Humane Technology. This is the same group that produced the movie The Social Dilemma. They've had some really good episodes lately about the perils of AI. I encourage you to go listen to those. And I also finished a series from Wondery called Flesh and Code. It mostly follows this one specific story of this guy that had an AI girlfriend and how the whole situation progressed. Very, very interesting. It's a whole new frontier of relationships that's coming about with AI technology. So I think where I am with AI right now is don't be afraid of it. It's a powerful tool. It can be very helpful, but use it with some common sense and caution. And that's probably good advice for pretty much every tool of any type that we have, or technology of any type that we have, right? And any medicine for that matter, medical procedures even. Risk versus benefit. It's that with everything. You always got to make sure the pros outweigh the cons. Okay, so it's time for an H topic in our Alphabet Soup series. And with hepatitis B in the news this week, I thought I would cover that. Liver stuff can get kind of complicated just because the liver has so much to do with everything. So this is something that I try to keep in very simple categories and terms in my head. So I'm going to try to explain it how it makes sense to me. Maybe that'll be helpful to someone else. Hepatitis is a non-specific term that just means inflammation of the liver, like any other itis. Most frequently, we think of that being caused by viral infections, which we call hepatitis, and then we use the specific virus we're talking about. So we say hepatitis A, hepatitis B, C, D, E, etc. But hepatitis can also be caused by toxins or drugs. The liver filters everything that comes into our body. You've heard of a HEPA filter, right? HEPA filter, HEPA liver filter. That's what it does. So there's a lot of potential for things to affect the liver because it plays such a big role in filtering everything, right? Essentially, everything flows through there one time or another, somehow or another. So it's very subject to being damaged. The symptoms that we think of with liver disease are common to any liver disease. If the liver's not working right, the symptoms are all the same, regardless of the cause, really. Sometimes it helps to think about the different systems that the liver affects. So things that the liver has something to do with include glucose metabolism, converting ammonia to urea, metabolism of proteins and fats, storage of vitamins and minerals, making bile, excreting bilirubin, and metabolizing drugs. So maybe it would help to think in those kind of terms to figure out what kind of symptoms you're going to see if someone's liver is not working right. One of the most obvious things you see with profound liver dysfunction, of course, is jaundice. The patient turns yellow, or the mucous membranes turn yellow, the skin turns yellow eventually. It can be really striking. It can be subtle, but it can also be very striking. And of course, we can see that in newborns who are not able to get rid of their bilirubin quite yet. And that is where the yellow color comes from. It's just from bilirubin building up in the tissue that's not being gotten rid of by the liver. You get itching, aka pruritus, because you have the bile salts being retained in the tissues. Other skin stuff you see might include petechia, bruising, these spider angiomas, palmar erythema, muscle atrophy. Kind of the classic body habitus of a liver failure person is really thin extremities, kind of emaciated looking, but then this big gut because of ascites, the pressure in the portal circulation, meaning the circulation through the liver goes up, and so fluid backs up into the abdomen. You get gynecomastia, testicular atrophy. In more advanced stages, you start to see problems with the brain, so hepatic encephalopathy or coma, It's what we call altered mental status or altered level of consciousness due to the liver not working. There's this thing called asterixis, asterixis, where if you have the patient try to hold their hands up in front of them, so like arms extended, hands up as if you were trying to maybe push somebody away from you. If you ask them to hold their hands, they'll start doing this kind of flappy looking thing. If you've never seen it, there are videos of it available on YouTube or wherever. Just Google it and see what it looks like. It's kind of interesting. Another complication of the pressure in that portal circulation being so high is esophageal varices. So essentially, this is varicose veins that are inside the esophagus. It's really a huge deal if one of those things ruptures. I've definitely coded patients in the field that their esophageal varices ruptured, and it is a hot mess because there's a lot of blood coming out of where you're trying to do things like intubate and ventilate. When those things start bleeding, they don't stop. Somebody has to go in there and put a little rubber band around them or cauterize them or whatever to get them to stop. That can happen in the rectum also, by the way. Those veins are also connected to the portal circulation, so you can see the same kind of thing happen there. The liver gets big. If you're adept at physical exam, you can sometimes pick that up. Actually, percussing out the liver is something I think that's pretty doable. It's pretty easy to hear the difference in the note between the lungs and the liver. It changes from that tympanic, hyperresonant kind of sound to a very flat, dull sound. Maybe that's something I could actually demonstrate with a microphone. All right, I'm going to try it. Maybe this will be a disaster. I guess I'll just cut it out if it's a disaster. Okay, so I'm going to percuss over my chest here. And now I'm going to percuss over my liver. I feel like that might have actually worked. I'm going to play the two sounds back to back. So the first one is chest and the second one is liver, so you can hear the difference. I bet that's easier to hear in my headphones than it will be on whatever you're listening to this with, but try it on yourself and see if you can tell the difference. I bet you can. Of course, sometimes the liver is just so huge that you feel it, like it's just right there and you feel it because it's massive. And of course, it would show up on imaging studies, the hepatomegaly. Some lab tests we look at for liver inflammation would be the AST, ALT, GGT. Those are the serum aminotransferases. Also, that's the difference between a BMP and a CMP, right? A BMP doesn't have the liver numbers on it. So if you want the liver numbers, you order a CMP, complete metabolic panel. Those are the most commonly assessed things that show direct liver injury. They don't tell you why, but they tell you that the liver is pissed off about something. You also have alkaline phosphatase, ALKPHOS, and LDH, lactic dehydrogenase. And then because there are so many things that the liver affects, there are all kinds of other lab values that might be affected if the liver's not working right. So your serum concentration of albumin and the different globulins, of course, the bilirubin, the ammonia, clotting factors, which in turn affects coagulation times. So your PT, INR, PTT numbers can be off. And your lipids, glucose, a bunch of different vitamins, minerals, iron is a big one. So all kinds of things that can branch off from there if your liver's not working right. Labs and imaging, probably the most common ways of assessing the liver. You can look at the liver with MRI, CT, or ultrasound. Of course, you have the specialized tests that look at the liver and the bile tract. There's the hepatobiliary scintigraphy, which is a nuclear medicine test. ERCP is an invasive way to look at that by actually running a scope down into the biliary tract. MRCP is a way to do the same thing with an MRI, so that's non-invasive. May or may not use contrast with that. Then you have the specific type of ultrasound that they use to actually assess the stiffness of the liver. The one I'm familiar with is called FibroScan. I think that is probably a brand name. The actual test is transient elastography. So if the liver does become fibrotic, or we call it cirrhotic, you'll be able to see those changes with the ultrasound. Cirrhosis is the end result of liver failure. It's kind of like you have end-stage kidney failure. Cirrhosis is end-stage liver failure. It's where the hepatocytes die and just turn into scar tissue. So it just turns into a big lump of scar that's not working anymore. So now back to hepatitis B. This is a virus that causes inflammation of the liver. To me, this one is the scariest one of all the hepatitises because it's so easy to transmit. It's transmitted in all body fluids. So anything that comes out of the body can potentially carry hepatitis B. It can get in through your skin. It can get in through mucous membranes. It can be sexually transmitted. It can get in through bloodborne pathways. It can be passed from mother to child during childbirth. It has this very long incubation period where people can spread it without knowing they have it, without being symptomatic. It can live on surfaces for up to 7 days in bodily fluids. Pretty scary. So I'm pretty glad that we all have to get vaccinated for that. As healthcare workers, obviously we are more at risk for contracting hepatitis B, being people who deal with body fluids all the time. Other things that put you at high risk, of course, being born in countries that have higher prevalence of Hep B, or in regions of the United States that have higher prevalence of Hep B. People who have other similar infections, so if you already have hepatitis C or HIV, you are certainly more at risk of Hep B. If you've ever used injecting drugs, men who have sex with men, people who have multiple sexual partners or history of any sexually transmitted disease, people with end-stage kidney disease, including people undergoing dialysis. I've definitely met people who contracted hepatitis from dialysis. If you live with somebody or have sexual contact with somebody who has Hep B, if you're incarcerated, if you are receiving blood products, or if you are getting tattoos from not properly sterilized equipment, obviously they do screen donated blood for hepatitis B, so that risk is pretty low, but it's not zero because the person the blood came from may be in this period of time where the virus is present, but there's not enough of it to be detected by a screening test, so the risk is not zero. It looks like, just from a Google search, that the estimate ranges from somewhere between 1 in 63,000 to 1 in 300,000 units of blood in the US is contaminated with Hep B. That's a very wide range, so I don't know how accurate that really is, but there is still a risk of that. Most people who get hepatitis B are going to develop antibodies and get over it in 6 months at the most. This can, however, progress to either a chronic hepatitis, or you can have a carrier state where there's not active hepatitis, but they are capable of transmitting the virus. According to the up-to-date article on this, there are about 257 million people worldwide who are chronic carriers of Hep B. That's out of the 2 billion people worldwide who have some evidence of past or present infection. Obviously, the concern is that this progresses to cirrhosis or liver cancer, hepatocellular carcinoma. Testing for hepatitis B, I think this is probably really the most important thing that I'm going to talk about, because there are all kinds of different surface antigens, surface antibodies, core antigens, core antibodies. It's confusing. This is not something that I deal with very often, so I have to look it up and refresh myself about it every single time. So here are the available lab tests and what they mean. You have hepatitis B surface antigen. If that's positive, that indicates a current infection and ability to transmit hepatitis. That's true for both acute and chronic infections. That antigen will show up before the patient's symptomatic in an acute infection, and in a chronic infection, it's going to persist for at least 6 months, depending on whether or not they are a carrier. Then we have Hep B surface antibody. That means you have immunity, right? If you build an antibody to it, you have some immunity to it. That can either come from a past infection or from vaccination. So if you have this Hep B surface antibody without the Hep B core antibody, which I'll talk about next, this means you got your immunity from a vaccine. If you have both of these antibodies, that means you had hepatitis B and you have built immunity to it from an infection. So the Hep B core total antibody persists for life after you've had the infection. So if you have that, that means either you had it or you still have it. You can also look at this core total antibody along with the core IgM antibody to figure out if this is a past or present infection. So the core IgM antibody shows up during an acute infection and hangs around for about 6 months. So if you have both, that means you have an active infection probably, and if you only have the core total antibody, that means a past infection. There's another one called the hepatitis B E antigen that gives you an idea about viral replication. So if that hepatitis B E antigen is around, that means you have high viral replication and infectivity in people who have chronic infections. If that goes away and you get anti-hepatitis B E antigen antibodies, that's associated with lower viral replication and improved prognosis. And finally, we have hepatitis B DNA quantification. We use that to figure out someone's viral load in both acute and chronic infection. We can use that to guide treatment decisions and monitor how the patient's responding to treatment. There's a nice little table from a JAMA article from 2018 that summarizes all this and goes over the different combinations of positive and negative things and what you would see clinically in those situations. I'll put a link to the article in the show notes. It's one of those that you would have to pay for if you want to actually read the whole thing. So everything I just went over about the antigens and antibodies was a summary provided by Open Evidence, including the little table from the JAMA article. I just learned I can actually share my conversation here with Open Evidence. So I'll put a link in the show notes to the actual conversation that I just had with it. That's interesting. Gets neater and neater the more I learn about it. All right, so what do we do about it? How do we treat hepatitis B? This is not something I have any experience in, just full disclosure. So I'm going solely on reference material here and not any personal experience. with treating this. With an acute infection, one of the first things you want to think about is protecting people around the person who has it. So they recommend giving hepatitis B immune globulin and Hep B vaccine to people who live with and have sexual contact with the patient who are not known to be either immune or infected. For most patients with an acute infection, the treatment is going to be supportive. Less than a 1% chance that a person is going to get acute liver failure from an acute Hep B infection. And for healthy immunocompetent adults, less than a 5% chance that Hep B is going to progress to a chronic infection. Patients who are going to get treated with antiviral therapy for an acute infection are going to be people who have a more severe or prolonged course, people who develop coagulopathy, so if their INR is greater than 1.5, if they have marked jaundice with bilirubin greater than 3 milligrams per deciliter for more than 4 weeks after they initially present. Obviously, if you do have acute liver failure, so coagulopathy and encephalopathy, you're going to want to treat those people. For the folks who are going to get antiviral treatment, it's tenofovir or entecavir, and that's monotherapy with one or the other. You do not want to give interferon in these situations because it increases the risk of bacterial infections and can cause a further increase in hepatic necroinflammation in people who have severe hepatitis or acute liver failure. Chronic Hep B is more complicated. So this is a person who has hepatitis B surface antigen present for greater than 6 months. General approach here is going to be trying to figure out what risk factors they had that led to this and minimizing those. Of course, all the labs that we talked about, looking for other causes of liver disease that they may have, screening for HIV, screening for hepatocellular carcinoma, and then screening for liver fibrosis with the tests we talked about. Probably the ultimate way to look at the liver is to actually get a biopsy of it, of course. I should have mentioned that before with all the ways to look at the liver. But typically in chronic Hep B, you're not going to need a liver biopsy. Situations where you would need one would be where you feel like there's something else going on other than Hep B that you're not catching. If you have someone who doesn't really meet criteria for antiviral treatment, but there's some other reason why they would benefit from it, like they have some other kind of liver disease that would be contributory to liver failure in the long run. When you're thinking about antiviral therapy, things that you look at include whether or not they have cirrhosis, what the ALT level's looking like, and then the HBV DNA level. And again, just looking at an individual patient's comorbidities, risk factors, that sort of thing. For most patients, if we're going to do antiviral therapy, it's going to, again, be either tenofovir or entecavir. They both are pretty well tolerated. They both work pretty well against the virus itself. They both have a pretty low risk of creating drug-resistant versions of the virus, and they both seem to reduce the risk of hepatocellular carcinoma. Doesn't seem like there's any clear benefit of one versus the other. Another option is interferon. That's for immunocompetent patients who do not have cirrhosis. It comes with a higher risk of adverse events compared with the other two medications, so typically they reserve that for people who really need a finite duration of treatment. So like if you have a young person, somebody who's planning to get pregnant, and just really needs to or wants to get this over with, this would be potentially an option. There's another option called lamivudine. They don't recommend using that because there's a high rate of resistance to it. So that would only be used if the entecavir or tenofovir are not available. Another closely related medication is emtricitabine that may have a role for patients who also have HIV. The up-to-date article goes into a bunch of detail about different situations, different variations of presentations and antibody situations. I don't think there's any need for me to go into all of this. This seems like an infectious disease specialist kind of neighborhood that we're walking around in here. So I think I'm just going to leave it at that. A little history about the hepatitis B vaccine. The virus itself, hepatitis B, was discovered in 1965 by Dr. Baruch Blumberg, who won the Nobel Prize for discovering it. Originally, they called it the Australia antigen because it was named for an Australian Aborigines blood sample that reacted with an antibody in the serum of an American hemophilia patient. You'd think they would name it after the person. Kind of reminds you of old Henrietta Lacks, doesn't it? A microbiologist named Irving Millman worked with Dr. Bloomberg to figure out a blood test for Hep B. Blood banks started using that in 1971 to screen donated blood, which resulted in a 25% decrease in risk of contracting hepatitis B from a blood transfusion. 4 years later, the same two came up with the first hepatitis B vaccine, which initially was an attenuated live virus. The newer plasma-derived inactivated version of the vaccine was approved by the FDA in 1981. A second generation vaccine, which is a recombinant DNA type, came out in 1986. And that is what we are currently using today, I believe. The first official recommendation to use the hepatitis B vaccine was published by ACIP in 1982, and universal childhood vaccination was recommended as part of a broader strategy to eliminate transmission of Hep B in the United States in 1991. In 1995, they added the recommendation to vaccinate all adolescents aged 11 to 12 who had not previously been vaccinated. And in 1999, they recommended that all unvaccinated children less than 19 years of age be vaccinated. As far as how well all this worked, from 1986 to 2000, the rate of acute Hep B among children aged 1 to 9 years declined more than 80%. From 1983 to 1995, the rate of Hep B infection in healthcare workers declined 95% and is now lower than the rate for the general U.S. population. Since vaccination began in 1982, the prevalence of chronic Hep B infection has been substantially reduced in populations where rates were previously high. They give an example of some data from 1994 that showed that the prevalence of chronic Hep B infection in Alaska natives less than 10 years of age, so these would have been children born after the routine vaccinations began, was 0, compared with 16% among Alaska natives aged 11 to 30. So it seems like it works. I don't know if I was vaccinated when I was born or not. I was born in 82. I was born in April of 82, so that would have been before they first recommended that. I seem to remember having to get a Hep B series when I went to EMT school back in the day. I think I had my titer checked and then had to get the vaccine. And I know now before you go into nursing school or any other kind of health education, you do have to have your Hep B titer checked to see if you can prove immunity or if you have to go through the vaccine series again. I think that's all I have to say. If you have any questions or comments, please feel free to get in touch. Thank you for listening. Special thank you to our Patreon supporters. I hope everyone has a great disease-free week, and I'll talk to you later. All right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order.